Hi, my name's Lionel, and I'm a diagnostic radiologist here at Singapore General Hospital. I'm also the Chief Data and Digital Officer for the hospital. And welcome to this episode of the SGH Hospital of the Future podcast. Today, we're really excited because we have not just one, but two AI scientists with us, all the way from Mayo Clinic in Rochester, Minnesota. Dr. Dan Blezek and Dr. Andy Missert will be sharing with us their thoughts and their ideas about how AI is used in medicine and how it has transformed how radiology is practiced at Mayo Clinic.
Hi there, my name is Dan Blezek. I'm an AI scientist at the Mayo Clinic working in the Department of Radiology. I've been at Mayo since 2007, where I met Lionel when he was there as an informatics fellow. And delighted to be here on this podcast and let you know a little bit about our efforts in AI.
And hi, I'm Andy Missert. I'm also an AI scientist at Mayo Clinic, Department of Radiology. Started as an AI scientist in about 2019. Prior to that, I was a postdoctoral fellow also at Mayo Clinic in 2017. And actually prior to that, I was a particle physicist, so that was my formal training. So I bounced around a little bit, but happy to be in AI and happy to be here on this podcast. Looking forward to talking with you guys.
That's great. Really, really great to have you both on the show. Maybe we'll start a little bit with a bit of history then. I mean, quite a lot has passed since the time we first met in 2007. I think back at that time, the clinic, Mayo Clinic, was just starting out the MI3C, right? The Medical Imaging Informatics Innovation Center. Can you remember what those times were like?
Oh, it was a great time. We had a visionary leader, Brad Erickson. I have to give him credit for really having the idea to bring technology to impact the Department of Radiology. And really, when you impact radiology, you impact clinical divisions that depend on radiology for answers. So it was a great time where we had deep technical expertise coupled with a visionary who really wanted to see technological impacts into the Department of Radiology. And it was a delight to get to meet all the fellows, especially yourself, and really work with an amazing group. Also to have radiologists who were dedicated to, investing in technology and making it better. So yeah, it was a fun time. However, if you remember, our offices were in a terrible location, which caused all sorts of trouble, but yeah, it was a good time.
I remember the team was really small, right? And we were in that corner of the lab, the radiology informatics lab. And but what struck me at that time was that we had physicians or radiologists working together with the technical folks at IBM, and then we had also technical leads from Mayo Clinic itself, and you were like a mentor and a technical lead in the team. And it was a situation of like solutions looking for problems and problems looking for solutions, right? And we were hoping that sometimes there'll be an intersection that we'll find a good mix of things, right? And I think when you reflect back, I mean, the change has been tremendous, right? I mean,
yeah, the MI3C really set the stage for a lot of the innovations that we see today happening in the Department of Radiology. And probably key to its success was someone well-placed who had the ear of the institution to make the investment. And then, the second part of that was when the institution saw that the investment paid out. And then they continued to invest and make it happen. But I would say the real success was getting a good mix of people from a variety of different specialties, radiologists, clinicians, technical people, software developers, all together in one space, learning from each other, especially learning from each other. What's technically feasible, what's clinically useful, what would we use day in and day out, what can we actually build and deliver? And that has really carried the day to our, Mayo's investment now in AI, both broadly as an institution and specifically in the Department of Radiology. So yeah, it was a fun time too.
Yeah, a fun time and an amazing journey. So now let's fast forward to 2025, right? And now we're in the age of AI, and not just AI, right? Where it's generative AI. We've got artificial intelligence in the news almost every other day. We hear about its wonderful promise, right? The exciting things that AI is going to do for all of us in every facet of life. And at the same time, there are a lot of risks, things that we have to be careful about, things that we're not really sure. And it's also spawned new capabilities and new roles, right? I mean, both of you are AI scientists, right? I mean, if we just throw back a couple of years ago, I mean, if you said, I'm an AI scientist, not many people may actually know what that is. So maybe, Andy, would you tell us, what is an AI scientist?
Yeah, I'd be happy to. I mean, so this is a position, a role that really didn't exist, just a few years ago. So, and I would say even that term even today isn't really very well defined. But what it means at Mayo Clinic is we are people who are knowledgeable in AI, who are trying to work to build applications, translate them from research into clinical practice. At least that's the current role that we have in our department. So trying to be that liaison between research, foundational research in AI, but also have knowledge of the clinical workflows and try to build clinical applications, try to improve patient care. So you need to have some technical experience and knowledge to kind of bridge that gap. And that's really the role of the AI scientist in our department.
If I may add a little bit to that, in creating the AI program and especially this position of AI scientist, Mayo did something a little unprecedented where they made the AI scientist in the consultant track. So in many ways, we're peers with our radiology and clinical colleagues. Of course, Mayo is a physician-led organization, so there's peers and peers, but that really enables Andy and I and the other AI scientists to interact in a more collegiate fashion with our radiologists. They're not directing us, that we're partnering together. And it's a subtle dynamic, to be honest, but I think it's very important to have that collaborative feel and not a director, employee relationship. And that's, I think, I don't know, Andy, maybe you can fill in a little bit, but I think that's one of the keys to our success is and I take that to heart, this opportunity to really invest in that relationship. So I don't know if you want to comment on that.
Yeah, I mean, I agree. So I think it's analogous maybe to the position of a medical physicist, which also people might not really know, but this is a dedicated person with technical knowledge who can serve integrated in the radiology department that has knowledge, say, of the physics of the imaging systems, right? Or if you're doing radiation therapy, deep knowledge of the physics of radiation energy transport. So, I feel like similarly with this new technology of AI, you need to have this dedicated person with technical knowledge that's deeply integrated into the clinical practice and not just some third-party isolated person. So I definitely agree that integration is key. It's almost a new clinical role that's just starting to appear now just due to the demands of this type of technology.
No, I love that. The description that you gave, right? Someone to be a bridge, not just at the technical aspect, but into the clinical and the way things really work in a hospital and where healthcare is delivered. And I think one thing that really struck me about my time at Mayo Clinic was how collaborative the whole setup is, right? Everyone sort of consults one another, even in the clinicians themselves have a very consultative approach. And this now expands even beyond the clinical realm. But perhaps maybe if I just ask a little bit more, you mentioned that it's on like a clinical track. Is that right for the AI scientists? Because attracting and retaining such talent, such bilingual talent, right? People who have the ability to think deeply in two domains, it's really difficult, right? And if I remember correctly, this privilege of being in the clinical track is only for AI scientists and perhaps also the medical physicists as well, right? So they're on a track that's similar to the physicians, right?
Yeah, Mayo has 3 shields, we call them. There's clinical care, education, and research. And all the AI scientists have come from the research shield. And so we understand technology, et cetera, and moved into the clinical shield, which in and of itself is very important to remember. I remember every day, I'm here to impact clinical care, not to write papers, not to educate people. And that helps keep focus. And also that, that collaborative across the different shields, across research and education has really fostered, as you say, a good working relationship. radiology also has a very collegiate relationship with our neurology, our surgery, counterparts. And a lot of what we do actually serves radiology, but also serves the downstream clinician.
Here, I think that's really important, right? Even though we're talking about something that's very technologically biased, technologically focused, like artificial intelligence, but at the end of it, it's understanding why we're there, and the human aspects, the relational and the workflow aspects are so critical in making it work.
And I think if you're thinking of, key factors of success, I think this was one of the really important early on strategic decisions, was to put our work in the clinical shield, not the research shield, right? So you might think AI technology, emerging technology, yeah, we need some researchers here to work on that. But I know, as being a former researcher myself, that field, you can't always rely on them to do the translational aspect and actually go on and affect patient care, because you always need to be on the forefront, publishing papers, worrying about the next publication, the next grant. And it's actually not a natural fit to do the translation into clinical practice. So I think this was a really important strategic decision on behalf of our department to embed the AI scientists, not as part of the research arm of the practice, but actually in the clinical arm of the practice. I think that's been a key factor for our success, actually, from early on.
And you mentioned retaining people and attracting people. So, of course, Mayo has a very robust research shield, a research area, and it covers a lot of different areas across the clinic. And I think all of us having come from that into clinical care has been important, because we strive to meet the needs of the patient. We're not just doing research for the sake of writing papers and getting grants, but it's a very special niche, if you will, where you have the technical expertise and this desire to work in a clinical field. The big AI companies are paying top dollar for research. So we actually struggle to attract and retain people because hospitals have limited budgets, et cetera. But when you find the right mix of people, and I would say all our AI scientists have this desire to impact patient care, and you couple that with a good technical expertise, and those are the people you want. They are hard to find, for sure.
Oh, I can identify with that.
Yeah, I'm sure you feel
Definitely.
it. Right.
But that's what I love, right? I think in healthcare, the mission is really clear. And I think Mayo puts it very nicely. The needs of the patient come first. I think here for us at Singapore General Hospital and at SingHealth, we have something similar. We say patients at the heart of all we do, right? So I think that focus and putting it in the clinical shield or in the clinical domain puts it up front and center, right? That's the reason we're here, right? And everything else is secondary to that primary mission. So that's really lovely. I
was going to say, and it's also helpful to be in that clinical shield, because we don't have to chase after innovative research. We don't have to chase after the papers. We can take older, tried and true technology to address the problem. We don't have to constantly be looking for the new things. Yeah.
We call it boring AI. We're big fans of boring AI here, because it's boring for us as a researcher, but what's a boring project for a researcher can be a hugely impactful project for the clinic.
Exactly. Don't just go for the shiny objects or the latest algorithms, right? Sometimes a very simple solution can actually make a huge difference.
Yes.
Right? That's very nice. So perhaps now might be a nice time to take a step back and look broader at the benefits of AI and how it may impact healthcare. I think you have the very privileged position of working in a top healthcare institution in the world, working with some of the best minds in the clinical domain, deep technical expertise, and you've been in the field of artificial intelligence and algorithms, both boring and innovative and really cutting edge. What are some of the things that you see are the major opportunities for artificial intelligence in healthcare as we look into the future? What are some of the things that you think might be plausible, maybe even a bit improbable, but really exciting?
So my take on that is AI has a tremendous ability to automate the tedious, repetitive tasks. So for instance, if you can take something that a nurse does day in and day out that the computer can do, And if the computer can do it as well as the nurse, or 80%, for instance, as well as the nurse, now you've freed up that nurse from that task. And often we look at both the physical, aspects of the task as well as the cognitive burden. Oh, now it's one less thing I have to remember and think of. So I think there's tremendous opportunity to automate those repetitive things. And in the second area, and we can talk more about specific ideas in there, but a second area that's really important is having a computer measure things that a human can do, but due to the demands of clinical care, we can't ask a radiologist to take, some of the projects I've worked on take 2 or 3 hours to measure something and give a highly accurate value. That's just not cost effective. It doesn't make sense. It's much better to have the radiologist continue doing interpretations rather than take a huge chunk of their day to make a measurement. But that measurement that's so expensive for a radiologist or a different clinician might be hugely beneficial to the patient, might be hugely beneficial to nephrology or surgery or what have you. So automating repetitive things and making measurements where they're just prohibitively expensive right now.
What I hear is let computers and algorithms do what computers and algorithms do very well and very quickly, and let the people do what people do very well, right? And find value and joy in doing.
Exactly, and find places where people are doing what an algorithm should be doing. And if there's anything I've learned in healthcare, we tend to solve problems by adding people rather than sometimes looking for automation. And I think that's changing a little bit, where let's figure out if we can not eliminate a job, but take that person away from doing a repetitive job and get them doing what they should be. Mayo has this term of operating at the top of your license. So getting people away from those administrative tasks that aren't really operating at the top of, whether it's a nurse or a medical doctor or what have you, getting them working and focused on their tasks that they should be.
Yeah, and I think it's easy to overpromise and overhype with AI, right? I mean, you see all the hype, and I feel like there's a sense, oh, hey, maybe one day I'll walk into the hospital or the doctor's office and this glowing blue hologram will come out of the floor and diagnose, all of your, cure you right there on the spot. But I don't think that's the way it's going to go, at least not in the conceivable future. So actually, where I see a lot of the value in AI is in the collective actions of many small algorithms that are mostly working in the background, making your patient care just a little bit more patient-specific, a little bit more finely tuned, less variance, more consistent, and more accessible to a wide variety of people under different circumstances. So that's really where I see the value, is this kind of collective action of many small algorithms. So even bringing back, as you guys were mentioning, the earlier days of the lab, what's really changed since then? While the hype around AI now, well, this technology really kind of brings down the costs of developing predictive data-driven models, right? So before, you would have to have a dedicated team and a partnership with a large company and a lot of expertise just to solve one aspect of a medical imaging problem. Now you kind of have a playbook, you have a unified set of models, and AI has a unified platform for building these types of data-driven applications. So that's where I see the value and the change from where we're at maybe a decade ago, is that now you can build quite quickly lots of small applications that together really raise the bar for patient care. So I think in the near future, what you're going to see is not these glowing holograms, but just more efficiency in your scheduling, better quality for the images, radiologists spending more time thinking, and as you mentioned, Dan, working at the top of their license, less time going through individually segmenting out different aspects of the image. So I think it'll be this kind of collective action that really raises the bar for healthcare for everyone.
I love what you said about consistency. I remember when people think of artificial intelligence, many people think of, can you outperform a human? Can you be like 100% or 99.9% accurate? But actually, consistency is where an algorithm is really great, right? Whether you have an expert or a novice, humans, when we change shifts or different teams take over, there's variability in performance. But having an algorithm to smooth out all this, to make it consistent, is actually a very big win, especially in healthcare, where we can't afford major variations in standards or healthcare delivery, right?
Absolutely. And so if you like, I could even give an example from some of the work that we've done. So, across we have Mayo Clinic as an enterprise. We also have various other smaller sites, more rural sites that are managed by our organization. So across all these different sites, you might imagine we have a variance in the types of equipment. So specifically CT scanners, right? If you're in some rural site, maybe you don't have the most newest, latest, and greatest photon counting scanner. So one of the projects that we tried to do was to use AI to improve image quality through something such as AI denoising for the CT scanners, to try to raise that playing field so that everyone, no matter what door you walk into, whether it's downtown Mayo Clinic or in one of the rural clinics, we're trying to elevate that level of image quality to be consistent across the organization. So that was one of the early use cases that we found, was actually trying to go through, train algorithms on our high quality data that we have from our nice scanners, and then you use that to kind of level up the image quality across the organization. So it's just these small improvements in consistency. But when you start doing many of these across the board, it really adds up, I think, to improving patient care in general.
I want to go back and make a comment on the hype surrounding AI that we've seen in the last 10 or 12 years. I personally don't like it very much, because people have these very high expectations. But what's been helpful is as the hospital administrators and leaders view AI and start to think about all these promises, the glowing blue hologram, it opens the door, and it opens their willingness to invest in AI. And that's a significant change, if you will, because hospitals are reluctant sometimes to invest in technology. So we've been able to ride that investment that Mayo Clinic's been willing to make, in the sense of, we know we can impact healthcare. We know we can't make the glowing blue holograms, but there's a lot of things that we can do. And so we try and fight the hype all the time to deliver boring AI to give good solutions. But the hype has been useful to crack into healthcare. And I think there'll be a level setting, where the hype is now coming into the reality, and we're trying to show at least good value for the investment over time. But it's just a wide open field. Healthcare is a wide open field. I think the vendors try, but our experience has been, if you do it internally, organically, you can build the exact solution for your institution, rather than take the solution that works for all institutions. Like the CT denoising that Andy was talking about is a perfect example. There are vendors that do this, but we can do it for our equipment to address our needs, and that's been very, very powerful.
Now we're the tailors fitting the tailor suits, so no off the shelf suits for Mayo Clinic.
Yeah, and I think perhaps that's one important lesson that can be drawn from this, is that as healthcare institutions, and especially if we want to be a leading healthcare institution in the future, we cannot just wait for vendors or off-the-shelf algorithms to come and be implemented, right? We have to have some ability to create our own that are customized or localized to our unique case mix, our patient populations, our equipment, and things like that, right? So that's a tremendously important point. Anyway, for Mayo Clinic, I don't think it's going to be a blue sphere. I think it's going to be 3 shields. And the patient walks in and they sort of pick which shield they like. Yeah. Today I'm in the research shield, right?
Yeah, exactly.
Okay, good. Perhaps now would be a good time for us to segue and talk a little bit about how AI has been used in the radiology department specifically, and how Mayo has been able to harness different algorithms, put a process by which these algorithms are conceptualized, tested, operationalized, and deployed, and monitored. Tell me about how you guys do it every day.
Sure, absolutely. So Mayo again decided to invest in AI about 8 years ago, but the underpinnings of that was the MI3C, where we early on showed, hey, if we could automate certain things, there's a lot of promise. And I have to give a lot of credit to Dr. Kent Thielen, who was the Department of Radiology chair at the time, to listen to Dr. Erickson, to listen to a visionary. It's not often that visionaries are listened to, but our department chair listened to Dr. Erickson and really invested. And so in terms of how we do it today, as Andy and I are both embedded in the clinical practice, we spend a lot of time listening to our radiologists, listening to their complaints, if you will, or their brainstorming about, wow, I heard about this AI thing. How can it, I'd like it to impact my practice. I'd like it to impact my division. If you're listening to division chairs, I'd like to make neuroradiology better. Or I'd like to make abdominal better. And I spend a lot of time saying, hey, I go to division meetings. I heard this. Could we address this with technology? And sometimes the answer is no, that's just people, unhappy with the way things are. Or sometimes it's yes. I think we should really invest in addressing that. So I spend a lot of time listening. And then once we've listened and identified good projects, then we begin to execute. And a lot of times that involves taking a little time and doing a proof of concept. Is this even technically feasible? And then once we've identified whether it's technically feasible, we move into actually implementing it. And personally, I like to kill projects. It's one of my favorite pastimes to say, yeah, we can't do that, or it's not going to work right. So we've done a number of, I have this 3-week thing where I invest very heavily for 3 weeks in a project, show what we got to at the end, and hopefully that shows enough promise to invest in it. But that's just my personal work. We've also created an entire infrastructure, about 40 people that work on radiology. But Andy, why don't you?
Yeah, I think that was one of the key difficulties in building this is recognizing that there's this gap, right? There's a whole institution built around research, writing grants, publications. There's a whole institution built around patient care, clinical care. There's not a lot of institutional structure around doing that translation between the two. So I think one of the things that was difficult, at least getting started, was trying to build up that institutional knowledge and experience. And we developed something that we call the AI playbook, right? And so this is just the process, the governance structure, the roles and responsibilities of all the different team members for how do you get from this idea into something that's actually in front of the clinicians, helping patients, improving patient care. So I think just building that scaffolding was a big part of that early work. Building the scaffolding, building the playbook, trying to figure out who does what, and then once that's in place, then you can start moving along algorithms through the pipeline and learning as we go, as we often do.
So building this scaffolding and then making it a reality. I mean, we know that plans are plans, and often when it comes to execution, plans go out the window, right? So I think the principles of what we envision and the whole governance structure and the whole framework, I'm sure they must have undergone multiple changes and evolutions along the way, right? I mean, from what was initially conceptualized by the first chair to where it is today. And I understand that you even rolling out a different version of what was originally envisaged. Sure. Yeah.
When we started, there were just 2 AI scientists and 2 developers. And so we did everything, when we initially got started. And over time, the department continued to invest we started small and they saw that it grew. But one of the major innovations came when we realized that one team taking an algorithm through all the steps, doing the research or the basics, writing code to make it work within the clinical environment, monitoring the algorithm over time for bias and drift and addressing, technical problems. So some server was down and it didn't run. That was inefficient. And the teams, as we grew and had more and more projects, the teams found themselves context switching a lot. Oh, I'm looking at data from the last year of running this algorithm, and then the next minute or the next meeting, I'm talking about something that hasn't even gotten off the ground yet, collecting data and annotation. And that context switching and the addressing different aspects of the life cycle of an algorithm meant that everyone got good at everything, but no one got good at one thing. And that led to us about 18 months ago or so, the AI scientists in charge really having a heart-to-heart and being honest, brutally honest, and saying, what we're doing is not working as well as it should. And so that led to a natural evolution where, surprisingly enough, each of us had a particular area that we were very interested in, and we didn't have to fight over who got to do the fun stuff, because the fun stuff for all of us was different.
Yeah, thanks for volunteering, Dan, for being the translation guy. Yeah,
that's right. A couple jaws dropped when I said, well, this is the most fun to me, because no one else wanted that one, and we thought we'd have to draw straws. And
So how did that meeting go? It was just like over coffee, and then and it happened that the cookie crumbled very nicely, and everyone picked up the crumb which they liked.
Yeah, there was a growing recognition that what we were doing didn't scale. It's really hard to scale this, if you will. And Mayo was after building not just one algorithm, we wanted a factory. And so we target 4 algorithms a year, which is very ambitious. Sometimes we do more, sometimes we do less. But I think on average for the last 5 or 6 years, we've hit 4 algorithms. And we couldn't sustain the pace, because when you have an algorithm that's gone through the full life cycle and is in the clinical practice, there's a lot of maintenance on that. And you need a very dedicated team to do maintenance. And anyone who's doing maintenance can't develop the new algorithms. And so our pipeline slowed way down. Or I don't know if it slowed down so much as we could see it was going to slow down.
I mean, I think it's definitely an admission that there's so many different aspects of the problem, right? People tend to focus on, okay, we're just building this model, then something happens, then it's in front of the radiologist, right? So in reality, just for example, the integration, just going from the model and then trying to integrate with all the clinical systems, that by itself, you must need to get a dedicated team. And then when we become more mature and we have things that are out there that are being used by the radiologist in the practice, then all of a sudden things like post-production monitoring, maintaining the consistency of the product, dealing with any kind of errors or changes or issues that come up, because these are static products, but the clinical environment is very dynamic, and you start running into these challenges, and all of a sudden you realize, wait, we actually need dedicated teams for all this. This can't just be a fraction of someone's time. You really need to have someone dive deep into the different aspects of the problem. So it's a very multifaceted problem. It's not just building the model, but all those other integration and monitoring and deployment pieces. They all factor in, and they can be quite difficult, actually. I bet if you were to poll us, we would say that those have probably been the most difficult aspects, not building the models now.
Right. Yeah, and so the way the cookie crumbled and the dust settled was we have 4 very distinct activities, and 2 of the activities are so closely related that we moved them into one. But discovery is the idea of when we get a green light for a project, the discovery team annotates the data necessary, builds the models, vets them, does some exploratory data analysis, makes sure that the demographics of the data that went into the model reflect our patient population. Thankfully, here's one of the benefits. We don't have to worry about the world's population. We worry about our patient population, which is, not representative of anything except Mayo Clinic, Rochester. So when the discovery team has the algorithm to a certain point, then the product team takes over. And the product team, the goal there is to follow a fairly regulated process of taking the model, doing verification, making sure it hits our targets for accuracy or fidelity of segmentation to ground truth, figure out exactly what ground truth is, characterizing the environment it works on. Is it adults? Is it fail in pediatric patients? Characterizing it, if you will, not changing it, but just characterizing it, and then doing studies where we put the algorithms in front of radiologists and get their take on it. Is this acceptable for clinical practice? Then once the product team has done their work, it's handed off to the integrate operate team. And we initially viewed integration and operation as two separate activities, but they were so close that the teams were struggling to figure out how to keep them separate.
We also only had one AI scientist to distribute between the two, so yeah.
So
someone had to
Monday,
get merged.
Wednesdays, and Fridays were integrate.
Yeah, right, exactly.
And maybe a split of the weekend.
Yep. And so now we have an integration and operations team, and like Andy was saying, they're responsible for how do we get the data to the algorithm? How do we make sure that it's running appropriately? And then because we follow a regulated process for development, we have a plan for monitoring each algorithm. So they do the yearly review of the performance of each algorithm. And so far we've moved 2 algorithms, almost 2, all the way through the process. It was slow to get started. Everyone knew what they were supposed to do, but it was very different to have a dedicated team. And so there was a bit of backing up, I would say, at least on my team, backing up, learning what we needed to do, understanding how to transition a project from one team to another. We still don't have that down very well, I would say, and moving things through the process.
So I hear 3 buckets so far: discovery, product, and integrate operate. So these 3 are the major verticals where there's a transfer between the teams. It sounds like, in spite of having a good plan, you had to adjust and iterate along the way, right? So figure out combining, integrate, and operate. And you probably also discovered skill sets that you needed that were not available in the team, right? I mean, how did you all deal with these challenges when they popped up? You can't always find a person who does exactly the one thing that you need. Right?
Yeah, that's right. I mean, so big picture, the team that we build in each one of these divisions, or we call them pods. So there we try to at least diversify within the pod, and so having an AI scientist, but also we have data scientists, we have IT staff, we have a wide variety of folks, as well as a radiologist or a clinical proponent who is with us along the way to kind of drive that clinical aspect. So I think building that correct team is a key aspect because it takes so much specialized knowledge in different areas, and you need to be able to bleed in a little bit, but it's too much for one person to do it all. So for us, I think the 3 pillars in each pod is having someone represent the clinical need. So typically this would be, in our case, a radiologist or a clinical proponent to kind of drive, okay, this is what we actually need to do to improve patient care. The AI scientist kind of as a product manager who knows enough about the AI and also the clinical problem and task at hand to be able to kind of bridge the two to translate, oh, hey, when the radiologist says we need this, here's what it means in terms of model design, here's what data we need to collect. So doing that type of translation. And then also having what we would call maybe like an informaticist or IT support, someone who can really understand the clinical systems that we have to integrate with. And there, I think that's actually one of the hardest types of knowledge to get off the shelf is the institutional knowledge of how things are set up, right? So we have a few people on our team who have been with Mayo for a really long time that are just invaluable resources to find out, hey, I'm trying to track down this one data source, but I see some discrepancy here. Can you help me out? And they can help guide us through that process. So that 3 areas of expertise, and sometimes it's 3 people, sometimes it's 2 people in a team, but those are kind of the 3 pillars I think that you need in each part of this project.
It's been good, but it's also introduced an interesting challenge that I don't think we anticipated. I certainly didn't think about it. Prior to this change to go vertical, an AI scientist would work with a radiologist very closely through the entire life cycle of a project. Now we have the unfortunate circumstance where a radiologist has to work with different teams, and we're struggling a little bit to handle the handoff. Oh, I'm not working with Dr. Missert anymore. Now I'm working with Dr. Blezek. What happened? Because our internal structure is very opaque to our radiology team, our radiologists, and they don't understand, like, why are you working on this now, Dan, as opposed to someone else? We haven't solved that yet, but it is looming. I think it'll take us educating our proponents early on, saying you're going to work with different teams throughout the life cycle of this product, and we're going to try and manage our handoffs as best we can, but just be aware that that's coming. So that's been the major challenge of our change that I've seen.
Yeah, I think that's a recurrent challenge, right? Managing the clinician or the physician, it is a... But I guess putting it up front, probably like you said, makes a lot of sense, right? Because if we look at the commercial world, I mean, even like a team that does the initial conceptualization of a product or a company, and then later on when they start going big time and they're raising funds, then you hand off to another team, and when they go live and they start their company, again, it could be a different team. I think there's really expertise that needs to be harnessed at different stages, right? So this is probably the trade-off that we deal with.
Yeah. Fine-tuning to what predominant there.
So, I mean, that's really a remarkable story of how things were conceptualized, how things evolved. And, you've given a lot of examples of algorithms that have, made an impact, helped to bring consistency or speed up the way things are done. I think when you look back on the past couple of years or longer, what do you think are some of the things that you're most proud of, or some of the biggest benefits that you've seen AI bring to how healthcare is delivered at Mayo Clinic?
I would say the thing that I'm most proud of, if you will, is I don't know if I can take much credit for it. It sort of happened around me, so let's just put it in proper framework. Is being able to be a software engineer with a little bit of medical, MR physics background, who just has this burning desire in my soul to get algorithms in front of radiologists to make an impact to patient care. Being able to see that go from, before I joined Mayo as an industry, and we always had this problem, it took 10 years or so to get some innovative thing into the practice because we had to develop it and then sell it and et cetera, to move to Mayo where I could do something and literally the next day it's in the clinical practice. But what I'm most proud of is how we've been able to take that, at least my passion, and now realize it with a big team in so many different ways, where we started with just a handful of very simple algorithms back in the day. Thank you for the aneurysm detection work. And
I enjoyed every moment of annotating those thousands of aneurysms.
Yes, I know.
Yeah. It brought me great joy.
But seeing that grow from initial set of algorithms and this vision, that I'll credit Dr. Erickson, he really made it happen, into what now is 40 some people with a dozen, algorithms in the practice with a dozen more on the way. Seeing that grow has been the most rewarding aspect for me. Yeah.
Coming from a non-medical background, so I came in as a pure physicist, but I had this transition moment where I was working on a project. This was related to the CT denoising project, and there was a new scanner that had come in, and there was some physics limitations in the scanner, and one of the radiologists came to our group. I was a researcher at the time, saying, hey, look, we can't use this scanner until we fix this issue. And it turned out that we happened to have the tools on hand due to some of the research I was working on. And it was just like this switch clicked. I put away, I was very grateful to my PI, letting me put my papers to the side for just a little bit and develop this application. And I mean, it was, first of all, it was amazing to the team that it took, because I had never really seen exactly how applications are integrated into the clinical practice. So just be able to work directly with the radiologist, but then also the IT staff and some of the other informaticists, and try to figure out, okay, we have this algorithm, how do we plug it in? These were kind of the early days, right? But I remember when they first started using that scanner, I was actually in the procedure room, and I had my laptop open, and I was looking at the terminal, seeing the data stream in from the CT scanner. I'm all sweaty. I'm seeing the algorithm process. I'm waiting for it to go, and I see it pop up on the console, on the CT console where the radiologists were working. And when it worked, I was man, this is just the the coolest thing, right? To be able to see that project through. So I was really happy to be a part of that, and I feel like that kind of started the transition for me, at least away from research and more into that clinical side of things. It's just amazing to be able to see something that you've thought of and have worked on for a long time to actually see it make that impact. It was a really excellent experience for me. So this is why I'm glad to be doing what I'm doing. And now I think we have maybe 14 and counting algorithms now that we've deployed and continued to grow. It's been a really phenomenal opportunity and a great experience, I think.
Yeah, I mean, just listening to you share that experience is so palpable, right? The satisfaction, and the joy, right, that you get from it. And I guess, Andy, that's where you cross from one shield into another shield, right? So you made a little hop across to the clinical domain and never looked back since. Yeah. There are probably some listeners for this podcast who, are boldly going into AI, and others who may be watching from the side, some waiting for the blue sphere, some hoping for automation, something simpler. Are there any pitfalls or cautionary lessons that you think are worth sharing, again, from your experience over the past couple of years?
Yeah, well, dozens. The thing that always pops out to me when people talk about pitfalls, and it's not often thought of, and I guess you have to work in a clinical setting for a long time, but delivery of the results of your algorithm is extraordinarily important. And I think it's often overlooked because it's very boring. To your example, I remember the day when Andy's algorithm went live, or maybe it's the second version that we helped on, I can't remember. But here we have a brilliant researcher in the CT Innovation Center, one of the premier CT research organizations in the world, with a great algorithm. But until Andy was able to get that delivered, sweaty palms and all, to the radiology team that really needed it, it didn't impact patient care at all. And people, especially researchers, don't always think about how they're, going to go from the paper, magic happens here, and now patient care is impacted. And that magic happens here is a lot of work. It takes a huge investment of people cutting across different parts of your organization. And then once you have it established, you have to maintain it. So delivery and maintenance, I think, as unexciting as those topics are, is probably one of the aspects, the major pitfalls. And thankfully, our MI3C experience early on gave us a delivery platform that we still use to this day. It was serendipitous, really, that we learned so many lessons there that carried forward. So that's the biggest pitfall, I would say.
To paraphrase, to make magic happen, it takes a lot of effort.
It does, yeah. Magic takes work.
Magic doesn't happen magically.
No,
not
it doesn't.
in AI, right?
No, absolutely not.
Yeah, I think I'll expand a little bit on something you mentioned, just the aspect of the post-production monitoring and that the ability to handle change, right? So these algorithms, they go out, they're a static entity, and the clinical environment is very dynamic and complex. So that's really, I think, the biggest issue that we constantly have to deal with is the data changing, our practices changing, how well is the algorithm performing? We have this idea of, hey, we're building a factory, but to be honest, I never really like that factory analogy. I think of it more as a garden, right? Like things are a little bit more organic, the environment's always changing, maybe if you're not getting enough rain, maybe you're not getting enough sunlight, right? And so you always have to be kind of constantly tending that garden, and it's a much more kind of dynamic environment than just, shipping something out and then hoping for the best. So I think that's really the challenge and pitfall is trying to manage that dynamic complexity.
And occasionally a deer comes in and those
exactly.
Yeah. All right. So maybe the most difficult question of all. What's your first impression of Singapore after you landed?
Oh, first impression of Singapore. It's a beautiful city. I will have to say, as we were coming in, you can see just how green it is.
Oh, on the drive-in from the airport?
Yeah. See how green it is. I love that it's a modern city, but It's a phenomenal public transit. People are friendly. It's very clean. It doesn't, I've visited a number of large cities. It doesn't feel crowded like most large cities do. And really enjoyed spending the morning at the gardens by the bay and seeing all the beautiful, all the beautiful plants and things like that.
I'm glad you had that chance. In fact, all those trees that you see along, the magic also didn't happen magically. Right? I think it was a deliberate effort of the Singapore, our pioneering government, our pioneering leaders who actually planted trees. We actually have a tree planting day to make sure that, and we first started as a garden city, right? This was our vision. But it's now switched to becoming a city in a garden. So there's a subtle difference, but it's still a lot about greenery and stuff like that. So even in our campus, if you look carefully, there are a lot of very old and huge trees that are peppered across our campus. And these trees are actually protected. We cannot just take them down to build something without approvals. So that's something really quirky about Singapore. But even the trees are specially protected.
Oh, beautiful city.
I don't know, did you have any impressions, Andy? You went to Maxwell Hawker Center.
But I mean, my first impression of Singapore was that it almost felt too easy, right? I mean, I was expecting, usually you land, there's an hour wait in immigration, and then you try to figure out the bus system, but man, I landed and just walked out, and then before I know it, I was eating a bowl of chicken porridge at 7 a.m., spicy chicken porridge. It was great. It was, the time from landing to eating delicious food, I think, was the shortest I've ever experienced in any city, which is really great for me, especially when you land, at 6 a.m. and be able to find somewhere that's open.
I think that's the best metric I've ever heard. Yeah. Landing to eating time. Yeah.
Right.
I think
very important.
I think that's something we should track religiously.
Well, you should, because Singapore's number one, and then it's everyone else. So make sure to track what you're already winning at, I guess.
Customs was so amazing. I looked around to see if we missed something. I thought we were going to get tackled as we left the airport because I didn't declare anything. We just scanned our passport and off we went. So that's really great.
We've used AI to assess everything, your movements over the past few hours on the plane. Is it suspicious? Yeah. Dan, Andy, that was really great sharing, and really appreciate your time and all the anecdotes that you've shared. I think really gave us great insight into how AI can be used and deployed and really make a difference in healthcare. Well, thank you for joining us in this episode of the Hospital of the Future podcast. We look forward to having you again with us as we delve into the future, looking at what's plausible and maybe even improbable of how we deliver healthcare in the years to come.